Thank you very much. What wonderful talks. And again, I want to thank the organizers for allowing me to give this talk at today's program. I've learned a lot from just the speakers today, and I hope to be with you soon in Delhi. My family actually is in Delhi. They live,
Oh,
most of my extended family is there. So I enjoy coming there as often as possible. And hopefully, I'll make a trip back to India at some point to visit you all and do these talks in person. And it's my pleasure to give you this talk. This is a constant conversation I think we've all had as ophthalmologists, as retina specialists on blood sugar control and other controls of systemic factors. It's constant. We talk to our patients in clinic and we say, if you just did this with your blood sugar or your blood pressure, it's going to improve something. It's going to improve your diabetic retinopathy outcomes. It's going to make your diabetic macular edema not occur. And that might be true, but in the setting of therapy, when we're delivering anti-VEGF therapy, does it change outcomes? And that's the topic of my conversation today. This is actually a culmination of many, many years of research work on my team and what we have done here in Cleveland. And I've just moved to Cleveland Clinic in Florida now. So I'm in a little different part of the country, much warmer, much, much more like India in many ways, in the heat. But I've been very happy living in Florida now in Cleveland Clinic, and I'm actually heading up two of their hospitals now. I'm the president of the two hospitals, including and being an ophthalmologist as well. So it's a fun time in my career, but also a fun time to talk about this research work today. So I'm going to summarize the most recent data on progression. I'll talk about the risk factors for DME and diabetic retinopathy, and then we'll have a chance to look at overall what factors affect the outcomes. We're all aware that our patients who are diabetic are at risk of all of these microvascular and macrovascular complications. When we take care of patients with retinopathy and they have retinopathy, they're at increased risk of diabetic nephropathy, neuropathy, stroke, and coronary artery disease. And so diabetic retinopathy alone can be an independent risk factor for these diseases to progress. So it's important for us as ophthalmologists to first and foremost know when a patient has these conditions that there are other subsequent conditions that are a higher risk. And that's why it's very important to refer them back to their primary care physicians to risk stratify them for these events. And we're aware that in diabetic retinopathy, there's both modifiable and non-modifiable factors that affect progression of this disease. We know on the modifiable side, we tell patients that hemoglobin A1C is very important, controlling their hypertension, making sure their lipids are better controlled with statin therapy, and cigarette smoking should be discontinued. But there are also non-modifiable factors we're all well aware of, including the patient's age, the duration of diabetes, and one that's becoming far more common, at least in the US and abroad, is pregnancy. Patients are becoming pregnant much more later in life. And as a result, some of the hormonal therapy they're undergoing can induce gestational diabetes, which can lead to a higher risk of progression to diabetes in their future as a result of pregnancy late in age. And so that's an important one to remember. So the question that we ask patients all the time is, does metabolic control affect the outcome? Your patient sitting in your chair and they're obese, they might be smoking, they might have obviously a hemoglobin A1C that is very high, and they might have increased age. Do any of these baseline factors affect the outcomes of a patient who's undergoing anti-VEGF therapy for diabetic macular edema or diabetic retinopathy? Well, we're well aware that if you look at the level of hemoglobin A1C, that the higher your level of hemoglobin A1C is and the higher your duration of diabetes, it is a significant risk factor for progression. And this slide really illustrates that very nicely. In the far right corner, you see that having a hemoglobin A1C of 7.5 or greater can be almost a two-factor increase of the progression over having a hemoglobin A1C well within the range and having a duration of diabetes that is equivalently as long. So again, hemoglobin A1C is a very, very important risk factor to control in this condition. And we also know that intensive control, telling a patient, for example, that you need to change your control, can become a reason for worsening diabetic retinopathy. And this has been studied in a meta-analysis that has found that increasingly tight control of blood sugar in a rapid fashion can cause diabetic retinopathy to actually worsen in the transient phase. And this is thought to be due to insulin, which stimulates VEGF production. So if you put a patient, for example, on insulin therapy and their hemoglobin A1C drops from 9% to 7%. That can also cause VEGF production and worsen the retinopathy. So the answer is potentially that we might want to be a little bit more gradual with this. And we saw this actually in the DCCT, which is the landmark study you can see here. On the right side, you see for the first 2 years, the intensive control patients actually had that effect, that they had a worsening of retinopathy for the first 2 years as a result of intensive therapy. Probably no greater study that we did here at the Cleveland Clinic was actually about patients like this one who underwent gastric bypass surgery for obesity, and they dropped 100, 150 pounds, but also had a rapid improvement in their blood sugar control. This was the results from the study, which showed there was a 3% decline in the hemoglobin A1C in those within the surgical arms in the study versus those in the medically treated arms. So again, showing you that it's important to control the patient. You're seeing a very good control patient with surgery, but does that worsen retinopathy? And we did this study with our patients here in Cleveland and found at 2 years and 5 years after this condition was treated, there was no worsening of retinopathy, at least in the patients. Now, one of the big problems with the study was very few patients had retinopathy at baseline. So maybe in a population that is enriched with advanced disease, we may have seen a signal. But in these patients, many of them did not have retinopathy at baseline and therefore had little progression after after the dropping of the hemoglobin A1C due to gastric bypass surgery. We're also aware that lipid control can reduce the progression of diabetic retinopathy. This is the results from the field study, which is using a drug called finfibrillate, which is a lipid control agent. We use statin therapy more than finfibrillate, but you can see retinopathy decreases, the rate of proliferative diabetic retinopathy decreases, and macular edema also decreases as a result. And we have results from the ACCORD trial, which showed that intensive control of glycemia and dyslipidemia and blood sugar and blood pressure control can all reduce the rates of progression in these studies as well, which is very important to see. One of the other, I think, important reminders is that some of the renal angiotensin inhibitors, lisinopril as an example, is a drug that can cause a lot of benefit, but they did not reduce the incidence of retinopathy and did not cause regression of diabetic retinopathy. So it is important for blood pressure control, but it doesn't have a direct effect, at least from many of these studies, on diabetic retinopathy progression or incidence over time. So let's look at the study that we talked about before. Does VEGF inhibition, when you're giving these anti-VEGF injections, does the level of control affect the outcome? And this came up because we did a study here in Cleveland of patients, and we found that those with a hemoglobin A1C of less than 7 had less robust improvements in visual acuity and OCT in the real world. And so we wondered if the clinical trials validated that. So we looked at both the RISE and RIDE studies, which was the 5-year study on the use of ranibizumab for diabetic macular edema, and the Vivid Vista study on a 2-year study looking at the use of aflibercept for diabetic macular edema. And here's the results of that study that we found. And what we did in this study was we looked at all these baseline parameters to see if they affected the outcomes of anti-VEGF therapy. We see great benefit to anti-VEGF therapy, good in visual improvement and good OCT improvement, but do they affect it based upon these values? And here you can see a plot of the patient's age on the x-axis. On the y-axis, you see the change in visual acuity. And you can see that this line is very flat, meaning there's very little relationship between age and improvements in visual acuity. So again, this does not appear to be related in this study. You can see here in body mass index, very similarly, linear relationships, not showing you a significant concern here with regards to worsening or bettering of vision with higher levels of body mass index. And some patients were even at the BMI of, look at this, 50 BMI. So they were really quite heavy patients in the study, and yet they did not show a relationship to this all. We looked at renal function, didn't see any relationship here. We also looked at levels of glycemic control, baseline hemoglobin A1C here. You can see all levels of hemoglobin A1C that were enrolled, 10 and 12. Some of these patients were enrolled, and yet this line is very, very flat, meaning there's no relationship with vision improvement and this hemoglobin A1C and blood sugar and hemoglobin A1C. This is also looking at the change in blood sugar and change in hemoglobin A1C over time. Some patients actually had worsening despite being in a clinical trial. If you can imagine getting injections once a month for 2 years, you'd think you get better at your blood sugar control, and these patients did not. And yet there was a linear relationship here between improvement over time. And we also looked at the drugs they were using and did not see an improvement. So the results from this trial were at least that there was not a relationship between any of these baseline factors and the outcome that we saw with regards to therapy, which is great to say that the therapies are superior to any of these baseline factors that are there. We also looked at the Vivid Vista trial, which is another trial that looked at this, and we looked at age, gender, and race to see if there were any relationships. Again, no significant relationships here with visual acuity improvements, and whether you're white or whether you're male or female or whether you had different age. We also looked at BMI, renal impairment, history of hypertension. Overall, did not see a significant relationship with regards to these outcomes. One of the most important findings, though, I can tell you about the study was that in this study, they compared laser to anti-VEGF in the trials. And what they did see, however, is if you look at those patients who received the anti-VEGF injection, they got equal visual improvements despite quartiles of hemoglobin A1C. You can see the hemoglobin A1C quartile here. But look at this level of improvement with regards to laser. The result of laser improvement, they had some visual improvement when their hemoglobin A1C was good, but when they got up to higher levels of hemoglobin A1C, there was no improvement in visual acuity. So laser therapy, what we use focal laser therapy for DME every so often now, less than in the past, can improve visual acuity, albeit that it does not improve visual acuity, especially in those with patients who have higher levels of hemoglobin A1C. And here you can see the OCT improvements in those patients over time. So we also, found in Protocol T, which is a more recent trial, looking at all three drugs to see if there was a relationship. And the answer was there was some slight relationships, but again, these weren't really robust relationships at all. So we did not see that as well. Now, one of the other areas of improved treatment is around anti-VEGF therapy for diabetic retinopathy. And here's just at a wide field. I love the talk that was done on wide field imaging. We use this all the time in retina. And this is a patient who I treated for diabetic retinopathy on baseline with severe non-proliferative disease. And now after therapy, you can see significant improvement in the diabetic retinopathy severity score. And we can debate on why we should do this or not, but I find this to be a very effective therapy for patients to reduce their progression to proliferative disease. So the question was, again, in these patients we're using this for, do we get a improvement in diabetic retinopathy equivalent with these baseline factors when we're using anti-VEGF therapy? So we looked at the results. And again, in the study itself, you saw about a 38% improvement in two-step retinopathy improvement within the trial, and as compared to laser within the trial. And we looked again at these baseline factors, hemoglobin A1C, duration of diabetes, body mass index. Did they indicate a better improvement in retinopathy as a result of having some related disease? So here's age. For example, there's no significant relationship here between higher ages and lower ages with regards to improvement of retinopathy within the trial. We looked at diabetes duration. There wasn't really a signal here with regards to longer durations or shorter durations of diabetic retinopathy severity. We looked at hemoglobin A1C. Again, did not see much of a relationship here. And we looked at by diabetic retinopathy severity scoring. And this is where we saw that severity scoring really mattered here. This is when we saw relationships with higher levels of severity. You had more likely an improvement with anti-VEGF therapy versus lower levels of retinopathy. So this was the only relationship really seen with all these studies. So, I think what I'm trying to hopefully get across to you today is that anti-VEGF therapy is very good at controlling both diabetic macular edema and diabetic retinopathy. And I think as ophthalmologists and retina specialists, we counsel our patients on how they should control their systemic disease. But in fact, what we can also quietly tell them is that despite their control of their systemic disease, we can control it with anti-VEGF therapy in clinical practice. And the studies validate that these baseline factors don't have any relationship with regards to the outcomes we see with these patients. So we can feel very comfortable as ophthalmologists and retina specialists that we can treat these patients. Now, I'm not advocating, please forgive me, I'm not advocating for the fact that I would tell your patients to not control their blood sugar, their hypertension, all of these things. Those control all the other systemic factors, the nephropathy, neuropathy, the cardiovascular risk factors. But I can say if a patient is getting therapy for these conditions, the only considerable factor really is potentially the fact that they have a higher rate of retinopathy at baseline. So I just wanted to stop and pause there, and I really appreciate the opportunity to speak. I wish I again could be there in person. I miss the food, the people, the colleagues I have in India, and I hope to make a trip back soon enough to see you all in person. Thank you very much.
Thank you, Rishi, for this very enlightening talk. I'm sure there are a lot of questions here, but one question which keeps coming to my mind is that all of us, keep telling people to control first and then start. So that is clearly borne out that we should not be waiting for control to happen. In fact, we can start even if the HbA1c is 11 or 12. We should not deny, because you said therapy is superior.
That's exactly the point. I had so many times where I met people and they said that exact comment you made, which is that go back and get your blood sugar under better control, exercise, lose weight, and maybe your retinopathy would improve. And the answer is that it may improve, maybe, but the answer was your therapy should not be delayed as a result of that. The patient's in your chair now, and we know that earlier treatment matters in this condition very significantly.
The only issue was legal implications. You see, especially in our country, I don't know about US, especially in our country, suppose a patient has a random blood sugar of, say, more than 200, and you go about injecting anti-VEGF agent to control DME, and God forbid if he had some reaction or some infection or this thing, then court is not going to spare you.
Well, the good news is that from the studies, there were patients who had these, and there was no increased risk of them developing stroke or myocardial infarctions or all those sort of things. And that is a very important, I think, topic to talk about, is the side effect profile of these drugs. The side effect profiles are mainly local. Systemic side effect profiles have not been figured out, other than when you give systemic Avastin or bevacizumab therapy. That's when you should be concerned about side effects. But otherwise, with these other drugs that are available, there is no relationship with that. I think that has been thought about, talked about, and again, in a very litigious society, I would agree with you. But I would say to you that also I think there's very little data to support that concern. And I think it's just a misnomer, unfortunately.
So one or two questions from my co-chairpersons, I think. Yes, Ajay?
Sure. No, I think you asked this particular question because of medico-legal purpose. I think what is more important, which you brought out, was that the hemoglobin A1c is lower, the laser affects better, which means that diabetic control is better, the laser is more effective. Why is that?
That's a great question. I think that when we are treating patients with higher hemoglobin A1c, that we are concerned about the outcome of this therapy, because obviously there's tight junctions that occur. We know that higher level of hemoglobin A1c means mainly higher VEGF levels, and potentially that tight junctions are not affected. Laser therapy only causes artificial scarring within the retina and can treat some microvascular disease, but does not affect the tight junctions. And so I think that that's probably what I would hypothesize, and I would love to hear your opinion on that. But my hypothesis is that because anti-VEGF therapy is affecting the tight junctions in the microvascular state, that the laser therapy is actually not effective in that, and that's probably why you see that effect draw out.
So thanks, Rishi. One last question.
Why don't all the studies have the subretinal exudates as a part of the protocol, or the microalbuminuria as a part of the protocol, to say how did they affect the results?
That's a great question, and actually we have done studies I know of in Rise and Ride with regards to subretinal exudates, and they do improve. When I trained here, I worked with my predecessor, who actually used to do surgery for subretinal exudates. He used to actually lift the retina up and wash the retina out. There was an advanced technique back in the early 90s that they were thinking this was good, but it doesn't seem to be beneficial. So that, I would say, anti-VEGF does improve that. Your second question about microalbuminuria, there's been a lot of studies about this. Actually, just recently in ophthalmology this month, there's a very good paper that came out that looked at anti-VEGF GFR and anti-VEGF therapy and found no relationship at all concerning that. So anti-VEGF therapy does not affect the ultimate GFR outcome in these patients. I think that's a very, very good paper that just came out just 3 weeks ago.
Thanks, Rishi. For the sake of time, we will not go further because time is running out. But all the people in the hall, they are very much enthused by your talk and a lot of learning actually. And we would love to have you physically sometime in near future. Thanks a lot for joining us.
Have a great day. Talk to you soon.
Thank you. Thanks a lot.